My name's Leanne Bisset, and my presentation today is on lateral elbow pain from etiology to treatment.
Download the free Physiotutors app now and become the best clinician you can be.
So, what I'm aiming to cover in this presentation is to look at lateral elbow pain in terms of the differential diagnoses that we should be thinking about. And part of that diagnostic process also includes thinking about pain mechanisms. So we're going to look briefly at nociceptive, neuropathic, and nociplastic pain mechanisms as they might relate to the elbow. We're going to cover some risk factors and prognostic factors involved with elbow, the development of elbow pain and symptoms, as well as the recovery and treatment planning as well. One of the things I want to just draw your attention to is this peripheral nerve entrapment, or this potential for neuropathic type symptoms to develop in the elbow. And I think this is a commonly missed possible differential diagnosis in the elbow. Anatomically, we have three big nerves that pass across the elbow, but also they spiral, they pass superficially, then dive deep. Their trajectory is really quite complex, and they pass through muscles, and they pass between muscle heads. They pass between a bony base, for example, the radial head, and then the muscles over the top of it. And so there is this potential for dynamic nerve entrapment in and around the elbow that I think we've got to be thinking about when patients present, particularly if they present with radiating pain rather than localized pain. So the ones that are highlighted there are both on the lateral and medial elbow sides. Clinically, as I said, it's fairly easy to diagnose. Pain should be localized to that lateral epicondyle region, which is that origin of the common extensor tendon. Half the population have these changes on imaging without any history of injury or any history of pain. And that work was done really well by Luke Heels and his team, and you can see the reference there on the page. So with that in mind, if half the population have these changes on imaging but have no symptoms, then it makes sense that the specificity, the ability of this type of image to rule in elbow tendinopathy as the source of pain is really low. It's no better than a coin toss. However, it is excellent for ruling out. So if you need to differentially diagnose, if you think there might be something else going on and you need to rule out tendinopathy, then the absence of any changes on imaging are a pretty good indication that they do not have tendinopathy. Diabetes, high cholesterol, glucose intolerance, so high blood glucose levels, so they can be diabetic or pre-diabetic, a current or former smoker, and also a past history of using corticosteroids, or particularly corticosteroid injections into the elbow. So these are all risk factors for the development of pain, but also can be involved in poor prognosis as well. From a drug-induced perspective, for elbow tendinopathy, corticosteroids are the most commonly linked drug related to that development, but fluoroquinolones and statins have also been associated with the development of tendinopathy, just not particularly with the elbow yet. Most of that is in the lower limb. So there's this fine line between underuse and overuse, this transition from healthy to problematic or pathological tendinopathy that is influenced by all of these factors. And many of these we would link to a nociceptive type pain presentation. In addition, we can do a varus stress test. So we apply a varus load, so that middle figure there that you can see on the slide, to see if that has a different end field compared to the unaffected side. So using our clinical skills if we are looking at the potential for some kind of neuropathic involvement in their presentation. This paper here did a nice study looking at, it was an anatomical dissection study looking at where the nerves run past the elbow and identified key points that we could use for palpation, because we know that if there is sensitivity within a peripheral nerve, palpation along that nerve is often provocative, often reproduces pain. There's a bit of evidence that there's a bit of equivocal evidence around the elbow. Oftentimes, smaller studies, smaller sample sizes have not found these pain catastrophizing or psychosocial outcomes to be associated with their pain experience. But Viana Vuvan in her thesis, so this is as yet unpublished in a journal, it is in her thesis, found that pain catastrophizing and kinesiophobia were higher in people with more severe symptoms, and that pain self-efficacy, so good positive pain self-efficacy, predicted better long-term outcomes, okay, for these patients as well. So if with a broad enough sample size where we can subgroup people based on the severity of their symptoms, those with more symptoms are more likely to show these kind of psychosocial impairments. We need to address maladaptive pain beliefs, address them early rather than later, even if you're very happy that this is just a local tendinopathy. And it looked at all types of exercise and it pooled all types of exercise with or without other treatments like manual therapy, for example, and compared it to other interventions. Now, there were a range of interventions compared, but these are the ones that sort of showed the most change. So exercise compared to corticosteroid injections, there were 8 RCTs that were pooled for this component, and they found that exercise was superior to corticosteroid injections in the short and long term. Isometric exercises make sense when you read the general literature around tendinopathy. Okay, the experts are advising against isometric exercises. Okay, and that's because isometric exercises probably make less sense for the Achilles and the patellar tendon. So this is a tool, it's readily available online. So I encourage you to download it and use this tool as a way of monitoring your patient's progress over time.